Hello. Can you hear me okay? Okay, I can see you, which is a good sign. But at the moment your microphone is muted by the look of things. You can't hear me. Okay,
I can hear you.
great.
You.
Thanks. Okay. Okay, so those of you who can hear and see us, okay, you are hopefully in the right place. Our host, I think, um, joined as an attendee rather than a panelist for some reason, and I have changed the settings slightly, but often Zoom takes a little while to catch up. So hopefully, if she rejoins, we will be able to see her, but bear with us whilst we are trying to get this resolved.
I'm having the same problems with the chat, so I'm going to drop out and rejoin.
Yeah, no worries, Anna. Thank you very much.
Can you hear me?
I can, yes. I can't see you currently.
Oh, am I still added? You had asked me to swap over to a panelist before. I wondered, would you need to do that again? Thanks,
Bear,
Trish.
bear with me and I'll give it a try.
Great. That's one hurdle out of the way anyway.
At least we can hear each other now. That's something. What I can't do at the moment is actually find you on the participants list.
Oh dear.
It's tricky, but we will
It's
keep on fiddling with it until we get there.
a
Um,
problem with technology, isn't it?
it really is. Okay, here we go. I've got you. Promote to panelist.
Ah, perfect. That's great.
Okay.
Perfect. I'm back.
I can see you and hear you, which is
Okay.
fantastic. It's always an interesting way to start a presentation, isn't it? But
I've not had much luck with technology today, so hopefully we're on the up now.
I was going to say, I don't think any of us have, but thank you very much for bearing with us. Do you have a presentation to share? Do you want to try sharing
I
a
do.
screen? Because that's the
That'd
next
be
hurdle.
brilliant. Host disabled attendee share screening.
Bear with me, and I will make you the host, at which point you have all of the power and I have none. So
I don't know
give
if I
it
want it, to be honest.
a try. I'm desperate to get rid of the power. So you are host now. Have another try, and hopefully,
I'm going to try and share my entire screen because this is how it worked for me before. So,
okay, it's looking good.
and then do from beginning. Oh, why this time? Fingers crossed. Can you see that?
Absolutely.
Brilliant. Can you still see me?
I can,
I
yes.
can't see any of you. It's a little bit disconcerting.
It is. So we set up as a webinar today. So essentially, the only person you'll be able to see is me, I'm afraid. You do have a large group of people here. So they can see and hear you, and we're getting lots of messages through the chat already. Last thing I'll say is just that if anyone has a question that they'd really like to ask, if you can try and put it into the Q&A function, we'll either ask as we go along or we'll save it until the end, ideally. If you use the messages, if you need any kind of technical support, etc. But otherwise, I think I'll hand over and leave you to it.
Thank you very much, and thank you everybody. It's fantastic to hear there's so many of you here to listen to me talk about my research. It's amazing. My name's Mary Rose. I'm a final year PhD student in Queen's University Belfast, but I'm also a senior behaviour practitioner in adult learning disability in the NHS here in Northern Ireland. So I'm coming at PBS from two different perspectives, which has actually been quite interesting in terms of the title of my research, which is the implementation of positive behaviour support in routine service provision. So what I will be talking to you about today, I'm going to give a bit of a background to why my research is important, I suppose. I'll describe the methodologies that I used through my studies. I'll look at the preliminary analysis that I've conducted. I really want to share with you some of the things that the service users, the family members and the staff members that I was so lucky to have as part of my study have said and the things that they've shared. I'll discuss these preliminary findings, and then what I'll do is I'll talk a little bit about my next steps and where I'm going from here. And the most important section of this for me is the questions and comments. So obviously, I know I'm so lucky to have you all here. You have such a wealth of knowledge, experience and expertise, and I really would appreciate any kind of feedback that you can give me at the end of this presentation. So I suppose we've heard an awful lot about PBS, and fantastic work has been presented today in this conference. And it's clear generally from the literature that there's a significant focus on how to most effectively support adults with intellectual disabilities, particularly those who present with behaviours of concern and in community-based social care settings. Research guidance recommends using database evidence to guide good social care practices and provide person-centred care, improve quality of life, and policymakers have identified that PBS is a framework which encompasses all of this. And it's particularly evident in things like the post-Bamford review recommendations across the UK, and more locally here in Northern Ireland, our policy for supporting adults with learning disabilities is constantly referring to positive behaviour support as integral to that. Notably, future planning for adults with intellectual disabilities in Northern Ireland continues to promote PBS, and this is evidenced in the draft learning disability service model that's currently being proposed by the Department of Health here in Northern Ireland, entitled We Matter. So despite this, and despite provision for adults with learning disabilities and behaviours of concern expanding and being described and recognised as best practice for this population, the evidence base for adults in terms of positive behaviour support is really very limited. Of particular importance are things that we've already heard about here today. So an acknowledgement of definitional inconsistencies across behaviours of concern and positive behaviour support in general, and also the lack of formalised universally agreed processes in PBS to guide practice and to quality assure the provision that we're providing. So I suppose as well, as part of my PhD, I'm currently trying to draft a narrative synthesis to propose as a paper publication. And I suppose this sort of encapsulates everything that I've just talked about. So the title of this will be Positive Behaviour Support for Adults with Complex Comorbidities. And what I'm hoping to do is look at the existing literature, look at those definitions, values and practices which already exist, and try to quantify those and see if we can reach a conclusion on next stage for those types of definitions, values and practices in PBS to apply to practice. So the aims and objectives of this study are as follows. So to explore the implementation of routine PBS for service users with complex coexisting diagnosis and associated behaviours of concern, and as I've said, to compile a literature review which reflects both the national and the international context of PBS. So I've noticed through my searching of the literature obviously as part of this PhD, there's an awful lot of discrepancy across PBS internationally. So what the UK is doing is different from what the US is doing, which is different to what Australia is doing. And we really want to look at that sort of from an umbrella perspective and draw all of that together. The objectives of the study then are to accumulate a multifaceted perspective of the applications of PBS in routine service provision, and to explore the actual perspectives of the service users themselves, to explore the perspectives of the families and the staff who are delivering PBS on the routine use of PBS in practice, and to consider the implications of the research findings for policy, for practice, and then for future research. And in line with that, my research questions you can see on the screen. So what are the perspectives of service users and their families on the use of PBS in routine service provision? What are staff perspectives on routinely implementing PBS? And what does routine PBS look like, which is the biggest question of all. For those of you who have bought CEU tickets, you might want to take a note of this and just give you a moment. Okay. And also, I really want to look, before we go into describing the methodologies and things of my studies and looking at the outcomes, I really want to look at inclusivity within the literature. So when examining the literature and exploring it, I really felt that for the, not all, but for the majority of the literature I was looking at, it was missing the voice of the individuals that we support. And that's really encapsulated within this phrase, "nothing about us without us," which is an empowerment slogan that has been used for many, many years for the most vulnerable in society. And looking at inclusivity and emancipatory literature and learning disability, I thought it was really important from the outset when planning the methodologies of this study that to include those individuals that we support, ask them, what are your thoughts and feelings about the way that you're supported? Have you seen your PBS plan? Have you been involved in setting out skills that you'd like to work towards and things like that? And I think the outcomes of those are going to be really evident later on whenever we look towards some of the things that service users were saying in the interviews. This is the general structure of my study. So it had 3 phases. The first was an analysis of untoward event data. I'll describe what untoward event data is in just a moment. The second part of phase 1 was interviews with the service users themselves and also with service user representatives. Phase 2 was focus groups with staff who implement PBS as part of their role. And phase 3 were direct observations of staff implementing PBS. So I'm just going to go through each of these just very, very briefly to give you sort of an idea of how exactly I did what I did in each of these phases. So for the first, the quantitative analysis of untoward event data. So you can see up in the corner of my slide there, I have a Praxis Care emblem. So Praxis Care actually was the sponsor of this PhD, and as such, all of my data collection and recruitment had to come from Praxis Care services. So in Praxis Care, anytime there is what they term an untoward event, so that could be other services may term them incident reports, so that that must be recorded on a system. And each of these untoward events are categorized. So some of the categories that I looked at were things like verbal aggression, attempted physical assault, property destruction, but that system also includes things that aren't directly related to service users' behavioural presentations, so things like medication errors and staffing issues and things like that, operational things. So I was able to directly access the service users' anonymised data following recruitment to be able to analyse the untoward event data across a 12-month period. But in order to gain access to the data, again, trying to include service users as much as possible in my research, I sought informed consent from the service users. There were lots of things that I did to support service users' understanding of what it was that they were consenting to in taking part in this research. And part of that was the production of these easy read documents. You can see just a section of them on the front page actually on the slide currently. So what I used was this software that Praxis Care use for their own easy read documentation. So all the service users were being supported by Praxis Care and they all were familiar with this software, which is called Widget. So I used that software to develop my easy read documentation to seek informed consent separately for the interviews. and then access to the data. So for this first stage of my data collection, the onboard event collection, I analysed the data just using Microsoft Excel. I actually had intended on using SPSS, if that's interesting to anybody, but there actually wasn't enough onboard event data to use SPSS in any kind of productive way. So that data is really used to illustrate behavioural presentation of some of the service users in praxis across a 12-month period. And then stage 2, which is the stage I hold closest to my heart, I suppose, was the semi-structured interviews with the service users themselves and their representatives. And I thematically analysed these with the help of NVivo 14 programme. My second stage of my study then were the staff focus groups. I actually extended my recruitment to all praxis care services, so every praxis care service that exists across the UK and in the Republic of Ireland. And I actually, for all stages of my study, I actually only managed to recruit from Northern Ireland itself. And in that respect, it was the 2 PBS specific services that exist within Northern Ireland. I think that's really important to remember whenever we go to look at the outcomes of this study. Especially these focus groups that I conducted with staff. So I was very lucky to have a focus group from each of the PBS services in Northern Ireland. But I will discuss the outcome of those later because it's interesting that differences in approach exist across even within the same service, praxis care. And these results were again thematically analysed using NVivo. And the final methodology I'm presenting, observations of staff implementing PBS. What I did was I directly observed the individual staff members routinely implementing PBS with one service user. So it was one service user and then obviously one PBS plan being implemented, but I was able to look at 16 staff members across a long period of time routinely implementing PBS with this service user. It was quite challenging to find a resource that supported the data collection of this. There's quite a lot out there that has been peer reviewed in terms of effectiveness studies, and there's a lot of resources for staff training and things like that. But when you're actually looking at what is PBS, if I'm looking at it, how do I describe and how do I quantify what people are doing that makes it PBS? It was quite difficult to find a resource, but I came across this wonderful resource by the PBS Academy, What Does Positive Behaviour Support Look Like? An observational checklist. And although it hasn't been referred to in the peer-reviewed literature and it's not a standardised tool, I just thought it was so useful as a tool. And in order to increase the validity and the reliability of that, I applied inter-observer agreement to it. But I'll show you, this is what the checklist looks like. Some of you may are most likely familiar with this already, and it supports a mixed methodological approach. So the first section, I'll just give you a sort of a flavour of this. The first section supports qualitative evidence. So you describe what is the person you're observing doing, what are staff doing, and examples of what was said to other people or other forms of communication used. And there's lots of space for that. And then there's multiple sections here for the quantitative data collection. So this is actually framed upon the positive behaviour support competence framework that you can see just on the screen, that was used to structure the structure of this actual resource. So they're scored on a score level of 0 to 2, and then you get a final score at the end. I'm at the stage of my data analysis for this last phase of my study, and I'm using these 2 resources, so Positive Behaviour Support Competency Framework and then this other fantastic resource from United Response, University of Kent, which is What Does Good Look Like? And that's what I'm doing currently, is mapping the scores onto these resources to get some discussion going of the outcomes. So after all that attempts, many attempts at recruiting people, obviously I've told you I ended up back in my own stomping ground in Northern Ireland for all of this data collection. what I managed to do was I got 7 people who consented for their untoward event data to be collected. I was very, very lucky and honoured for 3 parents and 5 service users to agree to be interviewed. And then again, as I said, I completed 2 focus served a full staff team of 16 people delivering PBS in practice to 1 individual. So I just want to take some time now to present the analysis of the untoward event data. Although it's not the biggest part of my study, I think it's really important to give a sort of context to the service users across praxis care in Northern Ireland. So as I said, 7 service users consented for this data to be accessed. And actually only 4 out of the 7 service users had any data that met this criteria. So I collected PRN usage across 12 months. So this was pain-based medication that was provided if, as and when required, and then non-pain. So typically for these service users, the non-pain medication was used for behavioural purposes, was things like lorazepam, diazepam, and some of the service users, as you can see on the screen, were prescribed first and second line for pain relief and first and second line for non-pain relief. And as you can see, the usage of PRN across 12 months, these service users really varied. Service user 4 at the bottom of the screen there only required pain relief, but there was actually quite a significant increase in the use of pain relief across the 6 months period. And that was the same for service user 3, just above it. We saw a similar pattern with service user 1, where pain relief usage increased, but it decreased across non-pain medication, and there was no second line. Although they were prescribed second line, there was no second line use across that period of time. And service user 2 actually showed a reduction in the use of pain relief and non-pain PRN across that 12-month period as well. The light pink section is the baseline measurement, the 6 months baseline measurement, and the dark pink, hopefully you can see it as pink, is the 6 months following that. And then looking at untoward events, very simply, it totaled up the number of untoward events that each service user was recorded as having across a 12-month period. So the baseline was 6 months and then follow-up 6 months. And you can see for service users 1, 2, and 3, their number of untoward events actually increased across the 6-month follow-up period. And that was really interesting because I actually removed things that maybe wouldn't have been applicable. So medication errors, staffing issues, operational issues were all removed from that. And it still showed quite a significant increase in the number of incidents. And as you can see, there's quite a large difference in the number of incidents between participants as well. And obviously service user 4 had 1 incident which was recorded as an untoward event, and it didn't have any in the preceding 6 months. So I really want to take the time to thank the service users and the service user representatives who agreed to take part in these interviews. They were so fantastic, and I got such a wealth of information from them. I'm just very honoured to have been allowed the privilege of listening to them and hearing their stories and hearing their thoughts, feelings, and experiences. And I just wanted to mention as well, the service user representatives that I managed to recruit were all parents of service users who were supported by Praxis Care and had quite a lot of experience with other services in the past as well. So key things that came out of these interviews were past life experiences and trauma, transitions, family, and inclusion in PBS plans. And I'm just going to go through each of these themes in turn and give you just a few examples of what people said. As I said, I got quite a lot of information from all of the people who took part in this phase, but I'd like to just share some of that with you, if that's okay. So for past experiences and trauma, these were both really interwoven and came really hand in hand. One of the service users that I was interviewing stated that, yeah, see, I used to be really bad. I used to hit staff and all. A family member stated it was very difficult when their son was removed from the house, very, very difficult, because it was either him go or my daughter for her sake. And I think that's why I try and do so much for him, because of the guilt I know we shouldn't feel guilty, but I do. And another family member described, we used to be in shock, real shock, if our son kicked off. The way they put him down, it was like 4 or 5 people, like a rugby tackle. But you have to remember, he was still a child, you know. When talking about transitions, a lot of service users and their family members referred to moves. So be that a move from their house, their family home, into supported living, into an institution, from institutions back into supported living. And one of the service user was really proud of the fact that now they live in a more, as they termed it, independent house than previous. And they said they used to live in a house that had other occupants as well, with a lot of staff, and now they live in a more independent living space with their own full house and one staff member, and that was so, so important to them. A family member stated there was nowhere here for him, so unfortunately he did have to go a lot further afield. Obviously, with him being away for so long, he found it quite difficult because I could only see him every couple of months traveling, because I have another child with severe learning disabilities, so having to bring her was quite traumatic. Service users spoke about family an awful lot, and this was particularly evident with the older population. One of the service users talked about bereavement. He said, see, I've got no family except his cousin. I get to see my cousin. My mum died. She died in 2018, and my dad died in 2019. But service users also spoke about their wishes for family in the future. One of them stated that they really wanted to get married to their girlfriend. What was really interesting to me when it came to asking service users and family members about their inclusion in PBS plans and about PBS in general was no service users had seen their PBS plans at all. They'd never heard of PBS. One service user representative out of 3 had seen their loved one's PBS plan. The rest didn't know what PBS was, didn't know that their loved ones were being supported using PBS, and certainly hadn't seen the plans or documentation around that. And no service users or their representative had ever been involved in the development, reviews, or subsequent reviews of their PBS plans. Despite that, service users and their loved ones all used language in their description of how they're being supported that would align with positive behaviour support. So some of these things were, well, they know all the triggers, they would have green, amber, red for monitoring his behaviour, that would dictate how they respond to them. There was reference to use of visuals, use of easy reads. One of the service users I interviewed stated that they have a chart. If they get 15 stars, they get to pick what their reward's going to be. Another referred to emotional regulation strategies that they'd learned. So that to me was very interesting. And it really shows that the people we support in their families, like they're aware of what works for them. They're aware that they're being supported in an effective way. So why wouldn't we include them in the processes of developing and reviewing their positive behaviour support plans? So preliminary analysis then of focus groups. I'm just going to give you a bit of a few of the key themes that came out of these focus groups. Just a bit of a reminder at 2 focus groups. So as I mentioned earlier, both focus groups came from Praxis Care Services in Northern Ireland, and they were both PBS specific staff groups. But it was really interesting when I came to meet with the staff teams to hear the differences in approach across both staff teams. So one of the staff teams in Group 1, they were supported by a PBS consultant who was employed by Praxis Care, and that PBS consultant did all of the behaviour analysis of the data that they were collecting and also wrote the PBS plans and reviewed those. Whereas for Focus Group 2, all of that was done in-house. So those staff members wrote, developed, reviewed the PBS plans in conjunction with the Trust, and they also collected and analysed their own data. Key themes that came out of the focus groups were training, and none of this will come as a surprise to practitioners on the ground, PBS autonomy, barriers to implementing PBS, data-informed practice, person-centred practice, perspectives of how PBS is implemented in routine practice, differences between non-PBS and PBS-specific care, and team rapport. So again, I'm going to go through a few of the quotes from these focus groups to give you an idea of what those thoughts and feelings were. So staff referred to in-house training, so a half-day PBS programme that's delivered by Praxis Care. They also referred to having begun the build PBS training, but the fact that that hadn't been completed at that stage. Of most importance to a lot of the staff was the learning on the job and learning from their colleagues. So there was shadowing mentioned, and although there was recognition that in-house training was provided, staff said that they feel they do a lot of extra training there themselves because the staff in Focus Group 2 have expertise in applied behaviour analysis. So the data collection and all the on the ground and, as they termed, reinforcement-based stuff isn't covered in general training, and they feel like that's extremely important. I mentioned as well, obviously at the beginning, the different approaches from the different services, and I think that's very clear in this theme, the PBS autonomy. Where Focus Group 1, you can see in the top two quotes, they're referring to the PBS consultant coming in. Yes, they're asking your perspectives and they're having everybody part of the plan, but they're not a part of the actual team. So they stated, I feel like if the PBS consultant was observing the service user, then we can get from his perspective and things like that. It would be more interesting. Whereas Focus Group 2 staff members, they do those observations themselves on a day-to-day when they're delivering direct care. So they stated things like, I've written the plans, review them quite regularly, but I feel like the guys have a lot of input in that they're telling us what's working. So the plans are shaped by the practitioners. And they stated, we have varying degrees of control over our PBS plans, dependent upon our relationship with the trusts. So they wouldn't 100% be in our control, but we're making those suggestions. And I think it's important to say that both of these teams don't have any interactions with each other. They work separately, but under Praxis Care Services, so they wouldn't be aware of the different approaches that they're following. So I think in that respect, it was interesting for Focus Group 2 to feel like, yes, obviously we have ownership over the PBS plans and the data collection and analysis, but we want more, whereas Focus Group 1 don't have any ownership over the PBS plans and data collection and analysis. But as you'll see in later themes, really want to push forward with that. Time and people was the biggest barrier to implementing PBS, and there was a lot of reference to that sort of co-role of practitioners in Praxis Care, where you're delivering the day-to-day care, but you're also collecting data, analysing data, and the fact that obviously the direct care role comes first. So staff have said things like, I think it's always been the issue is protecting time for staff to do all of this outside of the caring role that everyone does very well. They refer to when there's a behavioural crisis, everything gets dropped. And the fact that there's limited time for evaluation after incidents occur, which they said is the most important part of all. Again, there were huge discrepancies across both focus groups with data-informed practice, and that comes from the differences in approach, I suppose. Staff in Focus Group 1 really wanted to drive forward, taking ownership of their own data and analysis of this, whereas Focus Group 2, in being able to do that already, were able to demonstrate that the amount of data that they take and the variety of data they take had gone forward to reduce things like use of non-pain PRN, and then also inform the approach that neurology could take with that service users' epilepsy. Person-centered practice was at the centre of everything that the staff were saying. There were things like, if people are tired or whatever, don't let that overshadow your day and put the person who's support at the front, and about promotion of individual choice. I asked staff directly what their perspective was on how PBS is implemented in daily practice, and the answers, as you can see on the screen, were quite interesting because the staff were all finding it quite difficult to quantify what PBS is and how it's implemented in daily practice. There was a recognition that everything that they do is PBS and it seems natural, it's hard to explain. Staff said things like, it's in everything you guys do, like every interaction, every data collection, every time you're recording, but it was difficult to clutch on to sort of a salient description of what that did actually look like, which I suppose is why phase 3 of this study is so important. Some staff members that took part in the focus groups discussed how difficult it was to come from a non-PBS service into a PBS service, and actually all of the staff members who took part in the focus groups had never worked in PBS specific service before. One of the staff members said they found it difficult with so many plans to deliver them all individually to the service users that they support. And another mentioned that they'd worked in another scheme before that had a PBS plan, but it wasn't a PBS specific service. There was a lack of training. The plan wasn't checked or wasn't updated, and they saw a big difference coming to a PBS specific service where they had the autonomy to make database decisions and move forward with that. Apologies for the background noise. Team rapport was really important to all the staff, and that was actually really evident in delivering the focus groups. So the staff interacted with each other really well, they listened to each other, and they were saying things like trust in your teammates is really important, and that was most evident in situations where behaviours did escalate, and staff have said when service user did need support, you're looking to see who's behind you to know whether the situation is going to go well or not, and you have to trust the people that are coming through the door behind you. And they said as well that they find that quite difficult with the high levels of staff turnover, and then the use of temporary support from agency staff. You didn't have that trust or rapport with your staff team. Am I okay for time?
You absolutely are, yes. So you've got about 25 minutes left.
Oh, fantastic. That's great. So what was really interesting, I keep saying things are interesting, but of course my research is interesting to me. I hope it is interesting to you. But there were common themes across the interviews and the focus groups, despite the differences in data collection approach, and then also differences in the questions that I posed across both stages of my research. And I just want to run through these again. So the key themes that came across from everybody that I interviewed and who took part in the focus groups were staff relationships and rapport, communication, focus on meaningful tasks, skill building, service users' achievements and quality of life, institutionalization, and also familiarity with positive behaviour support. And again, I'm going to go through all of these in turn and just give you an idea of what service users, families, and staff members were saying about each of these areas. So staff relationships and rapport, a family member stated, I mean, we walk in sometimes some staff don't know we're there, and you can see them dancing away with their son and messing about. They're teaching him all different dance moves. A service user mentioned about the high staff turnover and stated the ones that have left I miss. Family stated, staff that genuinely, they're there to look after our son and they're not just there for a job. And then staff identified that there's a lot of new staff, agency, things like that, which makes it very difficult to implement positive behaviour support. So there's lots of aspects to these staff relationships and rapport that go lots of different directions here that were really important to everybody who took part in my study. Communication then is quite similar to staff relationships and rapport in that you can approach it from lots of different angles, but as a theme, it came up time and time again. One of the service users that I interviewed said that it was really important for staff to have a good, proper communication with one another to support him in the way that he would like to be supported. And he said that he found it really frustrating that he was telling one staff member something like, for example, a light bulb needs changed in his room, and then that wasn't getting passed on or actioned. And from a different perspective, it was also mentioned that the staff implement the use of visuals and things to support the communication of the service user. So they'll say things like, sometimes for it to really stick, they said sometimes a visual helps, and they would worry, the service user would worry that are they really going to get to Greg's, and is reinforced with a visual, and that's really effective for a reduction of anxiety. Staff then mentioned reference to a clinical practice group that they had, and said that was really useful for sitting down together. We can go, right, that's the plan, let's run with this, let's analyse that, and everybody gets a chance to build their skills with data collection and analysis. So focus on meaningful tasks and skill building. The word that came up over and over again with the service users was independence. The service users really, really felt that, or came across that they felt that independence was the most important thing to them. So it's coming up over and over again, mostly with reference to meaningful tasks or skills that they learned. So one of the service users said things like, I can do the kitchen, I can do the bathroom, I can do the laundry, mop the floors, hoover the floors, clean the carpets, get everything hoovered up, do the stairs, do the whole lot. And they were so proud of the fact that they were doing this. Now, the tasks and the meaning and the skills that were described by all involved in the study really very much varied, and that just emphasizes the person-centered aspect of positive behavior support in practice. So one of the family members described skills that his son had learned since being supported with PBS. One of the skills was loading the fork. If you load the fork or spoon, he'll take it from you and feed himself and give it to you back. You put rubbish in the bin. He knows not to give you keys or shoes to communicate that he wants out, and he'll check his fridge and give you food in it to open. And I just think that's just absolutely fantastic. There was mention across the board of institutionalization and also trauma and negative experiences that came with that for quite a number of the people that took part in the study. One of the service users told me that he had been in an institution for 11 years and 9 months, and he referred to the behaviours that he remembers displaying during that time. Staff members who were supporting a younger individual and then also an older man who had been in an institution for quite a long time. They said that they found themselves asking, like, why are you doing this job? But they were saying it's seen, especially with younger people, that it's important that they come to them when they're young in a social care environment, and then you get the trust, keep teaching them when they're young and get a better trajectory for later life to avoid that institutional situation that unfortunately the older population have experienced. In another setting, the staff had described how a service user who transitioned into social care setting from an institution hadn't left the ward for a significant period of time before they came to that social care setting and wasn't even going out for walks by the time they moved there. So service user achievements and quality of life was referred to time and time again. Family members described karaoke nights that they have for the son, and they described how happy he was, how he takes the time taking the mick out of staff saying he can sing, he can't sing. And they stated that his quality of life has dramatically changed in the last 2 to 3 years. Another family member stated that their son's quality of life had improved since moving back home to Northern Ireland, whereas when he was over in Scotland in an institutional setting, he wasn't able to access the community to the extent that he was now. And as a family member also stated that their son is now going out to a restaurant, which he never was able to do. He's going out to museums and different community activities. And they described how they'd recently gone to a toy shop and had chosen their own toys, and really was very, very happy about that. I think it's important to state that this quote at the bottom, it says, I think it's individualized for his benefit, not staff benefit. So none of these strategies are to make life easier for staff. They're all for the service user's benefit and skill building and quality of life, and it's led by him. And I just think if that doesn't encapsulate a really good, powerful PBS, I just don't know what does. So familiarity with PBS, this was extremely interesting. None of the family members, apart from one, were able to describe what PBS is. One family member said it's studying the behaviour and mechanisms and strategies to mitigate and cope with challenging behaviour, which I thought was really an excellent description. But none of the service users that I interviewed knew what PBS was. I approached it from lots of different perspectives to see if they were aware of any of the terminology to describe PBS. PBS, positive behaviour support. They did not, were not familiar with the terms at all, and neither were the other two family members that were interviewed. One of the staff members stated that I think other than learning about PBS slightly, especially if you don't have a background in it, it's kind of like good at the start to know what PBS is from working here, but I don't think the training is very extensive. I think you learn the majority of what PBS is like from working here and talking to the other staff who probably have more knowledge. So I learn more from just being here rather than just from the training. And I think that needs to be taken into the context of the fact that none of the staff members that took part in the focus groups had worked in a PBS service previously. Those of you who are collecting the CEUs, this is your second word, if you want to take note of it. Okay. So this is my final phase of my study, where I'll present half of the data that I've analysed for this phase. So this is direct observations of staff. Just a bit of a reminder, I observed 16 staff delivering day-to-day PBS, so just direct care with one service user following the same PBS plan. And in order to support the reliability and validity of this, I employed inter-observer agreement. And it was a board certified behaviour analyst who was my second rater for that purpose. And they co-observed 6 of these sessions. So this is my very preliminary analysis of this phase. What I did was scored up all of those sheets that you said earlier. What does positive behavioural support look like? And I put them into a percentage score. And just a reminder, all of these practitioners were delivering the same plan to the same person, had received the same in-house training. And you can see there's quite a discrepancy across the team with regard to their total score. And what I noticed was there was some commonalities with different sections, but there were differences as well. And I think that's going to be really interesting when it comes to looking at that in greater depth and maybe the ins and outs of why that was. So key areas that I want to explore whenever I'm discussing the outcome of my study are the importance of access to staff training on PBS and a consistent staff access to training on PBS, really good quality training, the impact of staff and staff turnover. I know that we're not going to get very far with looking at recruitment and things like that. It's a real issue over here in Northern Ireland and probably everywhere else as well. But we need to acknowledge the impact of that on staff teams and service users and their families. We also need to look at the lack of service users and families understanding PBS and ask ourselves, why is that? Or why has the time not been taken to sit down and explain what PBS is to the people that are being supported with PBS? We need to also look at the lack of co-production of PBS plans. The recommendations are that service users are involved in the development and review of their plans. And why is that not happening? How can we help? How can we make it happen, really? We also need to look at individual differences and cohesive approach to care across staff teams and service user relationships with staff and staff relationships with each other, the importance of that. The emphasis as well on quality of life for our service users that we support. And in line with that, the frequency of community access. So there were some service users who would have referred to outings which happen infrequently or in the past as favourite activities. So there was one individual who told me that his favourite thing to do was go swimming. But then later in the interview, I asked, well, when was the last time you went swimming? And he actually said, well, it was maybe about 6 months ago. We need to also look at the emphasis on emotional regulation because that's something that the service users were describing to me as something that was really important to them. The fact that they had these skills to now emotionally regulate themselves, and also they had the skills to approach the staff and seek support with regulating themselves. Every piece of research obviously isn't without its limitations and barriers, and for me that was very much recruitment challenges and access to service users. I did use the managers of practice care services as gatekeepers for recruitment, but I think in retrospect, if I were to do this again, I would make the time to visit the services myself where possible and speak directly with the service users using the easy read documents, ensuring that they're being used in an accessible manner, and really ensuring that they understood what it was they were accepting and declining. my next steps, I'm going to complete the phase 3 data analysis, both quantitative and then the qualitative data that came out of that resource. And then I'm going to develop my discussion considering the possible implications of my research findings for policy, practice, and future research. Thank you so much, everybody, for listening to that. I'd really welcome some questions, comments, and feedback if you have them.
Wonderful. Thank you so much. That was really, really interesting. I really love the focus you put on qualitative data, and getting the kind of views and experiences of people receiving support and also other stakeholders. You have a couple of questions already. If anyone does have any further questions, do please pop them into the Q&A. So the first one, I think I know the answer to, so I'm going to sort of reflect my understanding to you and then see if I'm right. But we had a question early on regarding how untoward events were categorized and analyzed to identify patterns or recurring risks. Now, my kind of assumption here is that that's not quite what you're doing at this stage, that the kind of analysis regarding patterns and recurring risks was being done by the teams
Yeah,
and
absolutely.
themselves. Whereas your analysis was more around identifying the characteristics of the people receiving support, right?
Absolutely. So the team leads in the services themselves, they recorded those untoward events themselves. The categories are, there's something like 30 categories within that system to record untoward events under. And I suppose if we're looking at it from the perspective of those focus groups, focus group 1 and 2, focus group 2 would really have been looking at that. They would have been looking at, okay, where are the patterns here? What can we do to prevent this from happening again? What proactive things can we put in place? Whereas if we were looking at it from the perspective of focus group 1, those staff don't have the autonomy to be able to be doing that. So I think, in answer to your question, it's the staff team that do that analysis, but the input that they have with regard to that varies very much across staff team and staff team.
Fantastic. Okay, thank you. And the second question we had was with a new white paper around special educational needs and education health care plans, families may not have to travel as far for school places. How do you feel about people with intellectual and developmental disabilities being supported in mainstream settings, and particularly the use of PBS to support them?
That's a really interesting question, and it's probably slightly different over here in Northern Ireland that I'm familiar with, but it's something that I'm involved with from a practitioner perspective. So maybe not so much with mainstream schools. There is a lot of sort of difference and challenge with accessing services, skill placements for individuals here who require them. And what we're seeing is the younger population coming up through the schools system. There aren't enough places in special educational needs settings for them, so they're being forced out into the mainstream settings to access their education. So I don't feel I myself am placed within adult services, so it's not something I'm completely familiar with. But I think that that's something that we're going to be seeing coming up with the younger people who are moving up into transition services. But I suppose for myself as well, as a practitioner, I'm going into special educational settings and supporting the schools for the transition, the people transitioning out of the special educational settings into adult services to implement PBS plans and make sure that they're up to date and reflective of their needs and wishes for moving out into adult services. That maybe doesn't answer your question completely, but it's the best I can do given my own expertise.
I think it is a good attempt at answering it. And again, it's not something that I'd kind of say is my particular focus area. But I guess on a really basic level, I'm always, um, I would always advocate for a really balanced view with these types of situations. The kind of really key point I'd say in respect to your question is that we need to look at that on an individual level. We know how important the context and the environment is for a whole range of outcomes for people receiving support. So, if a mainstream setting is the right place for them with the right support, great.
And I've also seen that in mainstream settings, there have been applications of PBS being put in place at a universal level. So things like PERMA, I've seen in mainstream settings all over this country. I don't know if it's being recognised as positive behaviour support, but there's certainly aspects of that that are being applied to every student in those settings.
And I guess that fits quite well with the next question that we have actually, which is someone has asked whether you have had any contact with services who use individual aspects of PBS without knowing it, such as antecedent behaviour consequence analysis and traffic light plans. What are your thoughts on that?
Absolutely, and it's more so as a practitioner rather than a researcher. I'm going into lots of different types of settings, so social care, day centres, things like that. And people are using the language relating to PBS, particularly like traffic light systems is used an awful lot. They're using things like reinforcement. Unfortunately, it goes the other way as well, and they're using terms like punishment and consequences and things like that. And it just comes from a place of wanting to do the right thing, but not having the education behind PBS to be able to drive your practice. And what we've been able to do, I suppose, in my service, which is a relatively new service within Northern Ireland, is support with education on PBS and what that looks like, and say to people, yes, I went into the service and I recognize that you're using this language. You're talking about what happened before, what happened after a behavior, or triggers and things like that. And that's fantastic that you're recognizing that. Did you know that that comes from a place called positive behavior support? And then moving forward with their understanding of that and implementation of more aspects of it.
Great, thank you. And then we've got another question coming in. Um, which what would you see as some of the main challenges when facilitating transitions from children's to adult services?
Oh, where do I start? I suppose the main challenges are that there aren't enough places in adult services. I can only talk about Northern Ireland, unfortunately, but things are not great over here. We obviously have that new model that's being proposed, and it's saying all the right things, but the problem is there's not enough money to
Mm,
implement the things that they're saying. And I'm seeing people who are coming from really good place in children's services, 18-year-olds who have had really good wraparound care, 5 days of school a week. They have access to respite services on a 3 weekly or monthly basis. They've got direct payment workers. And when they move over to adult services, despite transition starting from age 14 here, that can't be mirrored. It doesn't exist.
okay. Yes, which is difficult, right?
Very difficult for service users and their families. It's really very unfair.
Absolutely. Okay. We've got various people in the chat who are either thanking you for a really interesting session or agreeing with your point of people kind of the phrase used here is for falling off a cliff when
Mhm.
they kind of don't have the funding to support the service that they need.
I'll
Um,
be using this myself, I think.
I think that is the last of our question. Again, more kind of thank yous coming in and lots of food for thought. I think it's a really interesting piece of research. I'd really like to see it when you get to the point of a full write-up. As I said, I think particularly focusing on the views and experiences of people. I really appreciate it. I also really like um, using the PBS Academy tool. What does PBS look like? As you kind of say, there's maybe not so much research behind it, but in some respects, that's why it's so important that research starts using it so that we can actually kind of look at what that should look like and how it can be used more in practice. So thank you very much. Really enjoyed it.
Thank you, everybody, for sticking with me for the full hour.
Okay. Thank you guys. Bye.
Bye.